providing compassionate, experienced care for communities throughout the Northland.
Good evening and welcome to Doctors on Call. I'm Dr. Ray Christensen from the Department of Family Medicine and Community Health at the University of Minnesota Medical School, Duluth, and I am your host for the season's first program. Our topic tonight is heart problems. We'll be glad to take your questions about the diagnosis, treatment, and prevention of heart attacks, heart disease, and heart failure. Remember, the success of this show depends upon you, the viewer. Please call in with your questions and we will do our best to answer them. The telephone numbers can be seen at the bottom of your screen. Our panelists this evening include Dr. Jeff Adams, an emergency room physician with Essentia Health, St. Mary's Medical Center, and a faculty member at the Department of Family Medicine at the Medical School in Duluth. Dr. Alok Bachuwar, a cardiologist from Essentia Health Duluth Clinic, and Dr. Disha Mookherjee, a cardiologist from St. Luke's Cardiology Associates. Our medical students this evening are Eric Fritz from Owatonna, Minnesota, Tom Wisenan from Cokato, Minnesota, Mr. Jeff Rosso from St. Peter, Minnesota. I'd also like to welcome you to our 30th plus year. We've been doing this for a long time, and a shout out to our old mentor, Ben Owens, as we begin the program this year. Dr. Adams, you're in the emergency room and on the first line of heart disease most of the time and a lot of times. What kind of symptoms should an individual look at that would encourage them to come to your emergency room to be seen?
Well, actually, I would argue the point. The first line is your primary care doctor who's going to keep you out of the ER, which is by doing good preventive medicine and healthy lifestyle and doing the things that you should do.
Touche.
If that fails, then you end up in the ER. And if you end up in the ER, people present with different reasons. So classic description you've seen on TV shows are the crushing chest pain, the diaphoretic sweating, feel like I'm going to die, I have an elephant on my chest. And those people are actually fairly easy to diagnose. I mean, they're pretty classic, and we all know that symptom, even the public does. The problem that we run into is, unfortunately, most people don't present that way. And especially the young, the elderly, the female population can present atypically. It might be just an elderly person that had a fainting spell, or feels lightheaded, or feels a little short of breath, or sweaty, or nauseated. Some people don't have pain, they just have heartburn. And so someone's heartburn might be their heart attack. So it's very difficult to separate that out. So most of what we do in the ER is try to sift through that, and a lot of people get admitted for observation because of that.
Dr. Mookherjee, we were discussing before the show the difference between men and women. Would you like to address the symptoms and how they're different in women than in men?
Sure. Now, a lot of women still do get that crushing chest pain, and so we don't want women to think that doesn't happen. But oftentimes, some women just end up feeling significant fatigue, and it's been going on for a long, long time. Or they just have pain between their shoulder blades all of a sudden, or the heartburn that you mentioned. So even if a woman feels like there's something not right, and it's not what they're used to feeling, they should go into the emergency room and get checked out, because it could be a heart attack.
Dr. Bachuwar, you're an interventionist or an interventional cardiologist. Yes. Tell us what you do.
Okay. So I'm a cardiologist first, and then I've subspecialized in interventional cardiology, which means we're the doctors that tend to do some of the invasive procedures in cardiology. Namely, if my colleague here from the ER has a patient with an acute heart attack, and he would send a patient to me to take them emergently to what we call the catheterization lab and try to open up that artery. We use balloons and stents, which are wire mesh devices, to open up those arteries and try to allow blood flow back to that part of the heart.
So one of the questions that came up a little earlier, and either of you two can answer that, or Dr. Adams too, if I have my heart stented or if I get my bypass, Does that take care of my heart disease?
So I get that question a lot from some of my patients. They think that I had my stent, I had bypass surgery, I should be cured now. And that's only part of the solution. So what I like to tell people is that a stent or a graft for your bypass is actually just a Band-Aid. And what we really need to do is make sure that we're following a healthy lifestyle, eating lots of fresh fruits and vegetables, taking your medications is key to getting better, and trying to even prevent another heart attack in the future or progression of heart disease, and making sure that you're exercising and leading a healthy lifestyle is really the way to help improve your heart disease status.
Jeff, you took me to task in the beginning, rightly so. So what are the preventive things that we should be doing?
It varies depending on your risk, and your physician can assess your risk. There are several different tools out there, and you punch in some numbers, and they say, well, your 10-year risk of heart disease, which isn't necessarily heart disease. It can be peripheral vascular disease. It might be an aneurysm in your abdomen, or it could be stroke. They're all kind of clumped together. But we're talking about heart tonight, but they can kind of get a feel for your risk factors based on, unfortunately, your family, which you can't change. You can't change the fact that you're getting older, and the older we get, the more likely we are to have heart disease. But you can change things like smoking, and so if you're sitting at home and thinking about it, if you are overweight, if you've been told that your diabetes is maybe borderline, if you have high blood pressure, and if your cholesterol is kind of up in the air and you smoke, you have most of the risk factors for heart disease, and most of those are changeable. And it's working with your physician, but it's a project that you yourself as a patient has to take on. And not everything at one time maybe, but maybe kind of chip away at it. And you start at one pile, eventually you get all the way through and you get to the other side when you're living a healthy lifestyle.
Additional comments?
Well, some people think that if they are a runner or if they've been very physically fit their entire life, that they can't have a heart attack. And I like to tell some of and then they're surprised actually when they have high cholesterol or they do have their heart attack. And I like to tell them that it is still important that you pay attention to what's going inside your body, because you are what you eat. And so in addition to being fit physically, that's not always enough. Like you said, you can't change your genes, and so it's still important to pay attention to not smoking and what's going inside your body.
And
Go ahead.
sorry. One of the most important things is that this is a lifelong process. Sometimes heart attacks tell people that they have a problem that they weren't aware of before, and it's kind of a life-altering event. But effectively, everything that you do has to be a long-term solution, whether that be lowering your cholesterol, being active, watching what you eat. These are all things that you'll need to do and maintain for the rest of your life, not just fix something with a balloon or a stent for one day.
Right. And it didn't just happen overnight. It wasn't that you suddenly had a heart attack. Yes, you did suddenly have a heart attack, but the disease that's been going on inside your arteries has been going on for decades. It starts when we're young. So really making sure that we're eating healthy and having that good lifestyle right from when we're young and when we're children is really the key to trying to prevent future events from happening.
So the question comes up, we've been struggling with osteoporosis and calcium supplements and so on, and there's some undertow, I think, in the lay press lately about the possibility that calcium supplements can increase the risk of cardiovascular disease. Question from the public, any ideas?
Thoughts? Well, I know that there was some concern, and there's been some research done about valvular disease and calcium intake and calcium supplements. But as far as I'm aware right now, that it hasn't really panned out that taking calcium supplements actually actively contributes to coronary disease. I think the data has kind of washed out, so we're still not really sure about that.
And if you have a reason to be on a calcium supplement or you have osteoporosis, those are reasons to be treated. I would never avoid those because of concern of possible heart effects. If anything, we've learned more and more that the calcium we're seeing in arteries on valves is not related to the amount of calcium in your blood, but more related to inflammation and chronic processes that lead to those diseases. So
And
that's
I would
what we
agree
see.
with-
Yeah.
I would agree. I
Yep.
think it's great. Widowmaker. Hey, look,
All right.
what's the widowmaker?
So I find that interesting because I've learned about that word even when I was training, but I never really used it in clinical practice until I started here, and I seem to be hearing it quite a bit. But basically, the left anterior descending artery, I'll point it right here, going across the front of the heart is one of the larger of the arteries, and it supplies the majority of blood flow.
Go back and do it again.
Oh, sorry. Going across the front side of the heart is the left anterior descending artery, and that's one of the larger arteries supplying most of the pump function of the heart. So when people used to have disease in the beginning of that artery, they used to call that the widowmaker. They'd present with an acute heart attack and essentially have high mortality or die from this disease. Quite frankly, we treat that very differently now with what we do in the cath lab with balloons and stents, as well as what the surgeons do with bypass. We're able to address those fairly well, and I think the key is just presenting early, having continuity with your primary care doc in the ER, and getting you to the right people. So,
Jeff, aspirin a day in a 50-year-old male, should they or shouldn't they?
Most of the stuff would say yes. Baby aspirin a day is probably a good thing by the time you hit 50.
How much can you expect things like diet and exercise to affect your blood pressure numbers?
If you're losing weight, it'll make a big difference. If you don't lose weight, I don't know if you guys know, but I don't know much that says diet alters your blood pressure a lot, unless it's salt intake.
So from a diet standpoint, if you do have high blood pressure or other disease processes that lead to that, lowering your salt intake to somewhere between about 1,500 or at least less than 2 grams a day is what the current recommendation is. I think if you lose weight, it's actually fairly remarkable. Even losing modest amounts of weight, like 5 pounds, has profound benefits in terms of your blood pressure.
And even if you don't, actually, if you exercise, you'll notice if you're on a consistent exercise regimen, you'll see that oftentimes that works better to reduce your blood pressure and some of your cholesterol numbers and your sugar for those people who have diabetes than some of the medications do.
So you've got this link by your feet.
Yeah.
Why don't you hold that up? So we're talking about exercise. There's a nice heart walk coming up.
So,
That's right.
so this is an American Heart Association event here in the Northland. It's set here in University of Minnesota, Duluth. It's Saturday, the 28th. It starts at 8:30 in the morning. The walk is actually at 10 in the morning. There's several events for children, pets, information booths about heart disease. If you have heart disease, they have different groups you can join there. And they're essentially raising funds not only for heart disease, but heart disease specifically in this part of the country, and it all stays right here. So the website is www.northlandheartwalk.org for anyone interested.
Thank you. Disha, what are the side effects of statins? And this kind of came off a question on opinions on the use of statins in the elderly without heart disease with high triglycerides.
Oh, okay, so maybe we'll tackle the side effects first. So most people, I want to make sure that this is clear, that most people tolerate statin medicines very, very well. And the way that the side effect list gets generated is when they're doing a clinical trial with 20,000 people who are getting a study drug, and as the patients are coming in to the study, and while they're in it, somebody asks them, how are you feeling? And somebody will say, oh, I had a cough last night. And so, oh, that's the side effect of the drug is cough. And then the next person comes in and says, oh, I had a nightmare last night. And oh, side effect is a nightmare. So, but the main side effect that we really worry about with statin medicines, which is extremely rare, is severe muscle weakness or muscle pain. And it's usually proximal muscle weakness and pain, which is like your quads and your upper arms. So if somebody's taking a statin and they develop severe discomfort in those parts of their body, that's the one that we get really concerned about and that we say people should go to the emergency room for, where your muscles are breaking down. But again, it is extremely rare. I can't even count how many times I've ever seen it. So, but that is the main side effect that we get very, very concerned about.
Jeff, these are the tough questions. Creases in your earlobes.
Yeah.
Does that indicate you may have a heart problem?
I thought it did, but I don't know what percent or the reproductive ability of that finding. I think it's I don't know if they've actually done a true research. Do you guys know?
I've heard of that.
We certainly did learn. I apologize. I don't know the actual incidence with that, but
Right, it's the crease in the earlobe.
studies
I don't know if they've
quite
taken
low.
1,000 people and actually
No,
looked.
clearly not.
Well, I
don't
think
know.
there was, and there was a recent article, and I don't remember just where it was, but I
Sure.
just saw something on it too.
Sure.
So I think it's true, but that's the best I can go with it too.
Yeah,
don't
I've heard creases in your earlobe and dry earwax and thin calves.
Oh.
They were all in the same categories, increasing your risk of heart disease.
Jeff, what's the heart condition that sometimes kills young athletes?
It's the, if you looked at the heart, well, the one I understand, and correct me if
Yeah.
I'm wrong, the septum of the heart can get thickened up above, and it can cause an outflow problem. When the ventricle contracts, it pushes against this kind of thickened wall, and when it does that, it can, and if you work out, it can cause the heart not to function as well as it should, and you can get an arrhythmia. And so the people die from an arrhythmia probably due to heart muscle not getting enough oxygen. And then there's another syndrome in Laos in Thailand, which is named after a couple Spanish guys, which is an arrhythmia that's a genetic trait. And those people that's the most common reason for sudden death there, which is not related to a structural abnormality of the heart, they don't think. It's a genetic problem. But you can elaborate on the one more common in the U.S.
Sure. So one of the conditions is called hypertrophic obstructive cardiomyopathy. So just like you said, they usually present with a thickened septum or thickened muscle. It's an inherited disorder generally, so people tend to present in family clusters, but not everyone's always aware of those things or presenting that way. But it's tended to present in young high school athletes, college athletes, under extreme exertion, presenting with an arrhythmia, like you said. That's essentially a sudden fatal event.
I have several questions on atrial fibrillation, and I figured we'd eventually get around to it tonight. Jeff, what is atrial fibrillation?
I'm an expert because I had it. I'm an N of 1. I know atrial fibrillation. Atrial fibrillation is basically an irregular beat of the heart, and they call it irregularly irregular. If you imagine an orchestra, and the orchestra is conducted by the drum section that leads the orchestra, and all of a sudden the drummer is all of a sudden playing different instruments, no one's playing uniquely the same, and the different parts of the band are trying to follow different drummers, so things become very chaotic. And the atrium does that. The atrium is the drum section of the heart. It kind of controls the heart beating regularly. And so the irregular heartbeat that happens is the atrium's kind of firing away crazily, and the heart kind of filters that, and it contracts this time, and it may not contract, and it'll contract twice, and so you get this very, very irregular heartbeat that runs quite fast. For me, it was a problem just because I like to exercise, and when you lose your atrium contraction, you lose about 15-20% of your cardiac output. And so I'd run up a hill, and I get lightheaded and dizzy and need to lay down, and my people I ran with got nervous. So I actually ended up having what they call an ablation, which is kind of a big deal. But medications didn't work for me, so ablation worked for me. But it's a small subset of people that probably should think about having that. But atrial fibrillation, for most people, is tolerated very well. And if you control the rate, people do very well. And basically the biggest concern is blood clots. Because the atrium isn't contracting regularly, there's parts of the atrium that can kind of pool blood, and you get this little pooling, and the blood can form a clot, and that can cause a stroke. So a lot of people that are on have atrial fibrillation need to be on an anticoagulant like warfarin.
Disha, treatment.
Treatment of atrial fibrillation? Well, the first line of treatment is usually to control the heart rate. So if somebody comes in atrial fibrillation and their heart rate is going at 140 beats a minute, usually they don't feel very good when that's happening. So we try to slow down the heart rate with either beta blockers or calcium channel blockers. And then if the heart rate has come down and they're still very symptomatic from it, sometimes we'll shock the heart back into normal rhythm. Again, there's a scoring system that we use to figure out who is at higher risk of a stroke, called a CHADS 2 score or a CHADS VAS score, which stands for congestive heart failure, high blood hypertension, age greater than 75, diabetes, and stroke. And if you have you get 1 point for each of those, and you get 2 points for a stroke. And if your score is 2 or greater, then you really should be on an anticoagulant like warfarin, or we have newer anticoagulant agents out there now like dabigatran, or rivaroxaban that's out there. So that's also part of the treatment for atrial fibrillation to reduce your risk of stroke.
So you may want to plug your ears, because the next question is, Alok, how does AFib affect longevity?
Oh, I hope I understand what type of longevity they're talking about. But, generally speaking, the major risk of atrial fibrillation is stroke, as has been described. It's a condition that does present based on a number of factors, from high blood pressure, obesity, sleep apnea, all the way up to the most common thing is age. So as we get older, there's more people likely to have atrial fibrillation. As you described, it's fairly well tolerated, and so with adequate rate control, people do fairly well. The risk of stroke by using aspirin or warfarin as determined appropriate by the guidelines she was describing cut your risk in almost half of having a stroke. So generally speaking, if you're identified and on appropriate treatment and you treat the causes, you should do pretty well.
Does smoking marijuana lead to heart problems?
You know a 10,000 person study that looked at it? I don't know.
I don't know that. I don't know. The smoking marijuana. I don't think smoking marijuana, but I don't think it's been proven that smoking marijuana actually contributes to heart problems, but we sure do see people who come in with heart problems, either arrhythmias or chest pain or chest discomfort, and they have smoked marijuana, but I don't think there's a causal relationship that, not that I know of, at least.
In contrast, like cocaine, which clearly
Right.
can cause cardiac
Yes.
heart attack.
Right, right.
Absolutely.
What is a left bundle branch block? Who wants to?
All right. So the conduction system of the heart, without getting too much in depth in this, you have a pacemaker. Sorry, it's odd to look at this from the back. In the right atrium, so it's kind of the top right part of the heart. Thank you. And so that's your pacemaker that sends out signals for each of your heartbeats. That connects to some electrical fibers that are the wiring of your heart that go to kind of the middle of the muscle. And that branches into two sets of fibers called bundle branches. One's the right bundle branch, and the other one's the left. What bundle branch block means is when we look at an EKG, we can see findings that one of those bundles isn't working as well as the other one. So we see a change in how that EKG waveform looks. The main reason it's important is that, at least in the setting of someone presenting with chest pain, an acute heart attack is often a heart attack involving the front wall of the heart. If it's very extensive, it will present with that finding on EKG. So if you ask medical students, residents, physicians, whoever, that would be the reason that we're most concerned about that. Some people with heart failure present with other problems related to that in terms of how their heart squeezes, but that's the main setting in which I address it.
Mm-hmm.
Jeff, because I think it's an important question, I'll just let you go on this one. How dangerous is an upper aortic aneurysm?
An upper aortic
Upper
aneurysm.
aortic, yep. So that'd be a chest, I would guess.
Well, there's a little bit of a definition issue there, because the thoracic part of your aorta, which goes up from the heart and back down to about the diaphragm, doesn't usually form what they call an aneurysm. What it usually does is tear, and when it tears, it's called a dissection, and it actually kind of makes a new kind of false lumen or a false path through the aorta. Once you hit the belly, then that's when you talk about people with aortic aneurysms, which is a ballooning of the aorta that, if it gets big enough, it can rupture. So they're kind of two different things. Aneurysms in the thoracic are actually fairly uncommon. Dissections starting down in the abdomen are unusual. They both are dangerous. The dissections in the chest can mimic a heart attack, and they can have crushing chest pain, sharp ripping pain, feel short of breath, just like a heart attack.
After moderate alcohol consumption, the patient sometimes wakes up with a rapid heart rate. Is there a risk of having a heart attack during the night if the patients experience that?
Well, if they're experiencing a rapid heart rate after drinking alcohol, one of the first things that comes to my mind is the development of atrial fibrillation. And so that's really what the biggest concern would be, not necessarily a heart attack, but that their heart is in an irregular rhythm. I remember when I was in Chicago and New York and in training, you'd see college students who binge drink on the weekends, and coming in, they're young kids in their 20s or late teens who've binge drink at a fraternity party, and they come in rapid atrial fibrillation due to the excessive alcohol intake. So that would be the biggest concern.
Alok, how do heart murmurs impact heart health?
Oh, that's a big question. There are a variety of heart murmurs that we see. Basically, your family practice doc or your primary care provider is a good person to go to with this. If they hear it, they'll send you for typically an echocardiogram that will identify what that murmur is from. Any change in how the blood flows in the heart produces a murmur. So each of the valves or holes in the heart can all present with different murmurs. So bottom line, if you have one, I would show it to the doctor you see most regularly, and they'll be able to triage you appropriately.
Very good. Jeff, one last quick question. Any reliable blood pressure cuffs? My thoughts, talk to your pharmacist.
Yeah, there's several on the market. I know the electronic ones work.
That's what I say exactly. Talk to the pharmacist for which ones get returned and don't get those ones.
Wrist or
Preferably
arm.
arm.
I want to thank our panelists again, Dr. Jeff Adams, Dr. Alok Bachuwar, and Dr. Disha Mookherjee, as well as our medical students, Eric Fritz, Tom Reisenden, and Jeff Froso. Please join us next week when we tackle questions about immunizations and infections and infectious diseases. After all, it is cold and flu season, so have your questions ready for Dr. Ruth Westra and her panelists, who will be Dr. Paul Sanford, Dr. Brett Shepard, and Dr. Steve Teacup. Thank you very much for watching, and a good night.
But you took out my favorite percussion part? Where'd it go?
Steel here. Did you need that?
No, I've got mine.
So you guys are going to do some a specific kind of
Nice to see you.
therapy that was new? Is that what Carolyn meant?
Maybe I need to get up to speed. I wanted to tell you, I don't have DSM-5 yet. So if you have a question about changes, DSM-5 sort of changes, I'm not up to speed on that.
I'm not asking that. They don't care about that. They don't care about that.
I didn't think so, but just in case.
Yeah. But don't ask me a question.
Good question for Steve.
We're good, thanks.
Also talk about everyday issues that we all face, like work stress and how to get out of our own way so we can be happy. I'm so excited. It's going to be a great season, and we want you to watch Speak Your Mind Thursday nights at 7:30 on PBS North.
Coming up on Austin City Limits.
Saturday night at 10 on PBS North.
Do you think anyone's realised that we're missing?
There's somebody up there. Something weird's happening. Why's the car there and them not in it?
Where the hell are they?
Hang on, I'm not living under the same roof as you while you're having it off with someone else.
We know where the door is.
Sunday night at 7 on PBS North.
On Masterpiece Mystery.
Carl Strasser, Nazi. He's been an extremely valuable intelligence asset. We can't afford to lose him.
The greater good.
Exactly, Foyle.
We both want the same thing.
And what's that?
We want him dead.
We can't do this. This is getting out of hand.
They could prosecute you for this. You must be careful how many times you need to be told.
Foyle's War on Masterpiece Mystery.
Sunday night at 8 on PBS North. Production of Speak Your Mind is made possible by the Human Development Center. Comprehensive behavioral health care. If we don't, who will? Learn more at www.humandevelopmentcenter.org. Additional support of HDC provided by
Depression. It's a mental health issue we've all heard about, but did you know the World Health Organization predicts it will be the 4th leading cause of suffering by the year 2020? Find out more about this illness and the latest and most effective treatments tonight on the season premiere of Speak Your Mind. Welcome to Speak Your Mind. I'm Dr. Carolyn Phelps, licensed psychologist with the Human Development Center. We begin a new season, our 4th season, with a discussion about one of the most common mental health issues worldwide today.